Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. And today we are pleasured and honored to have Professor Wesam Ismail as a speaker as usual in one of her interesting sessions in this platform, as we used to listen and discuss with her her lectures always. I would like to welcome Professor Dawlat Bilal, the moderator of this session. Professor Dawlat is the head of Scientific Committee of Egyptian Fellowship of Nephrology, Ministry of Health, and she is Emeritus Professor of Nephrology and Internal Medicine, Cairo University, and the past chair of Asr Al-Aini, the Nephrology Dialysis and Transplantation Center in Cairo University. She will introduce Professor Wesam and lead this session and moderate, which is about AKI cases, AKI pathology in cases of acute kidney injury in a case-based discussion manner. Professor Wesam, as we all know, is the head of pathology department in Bani Suef University. She is the professor of pathology and head of the department, and she is the past chair of ISN Pathology, Renal Pathology Working Group, and the current chair of AFRAN, African Association of Nephrology and Transplantation Committee of Kidney Pathology. So I will leave the floor to both the great moderator and the great speaker to start this session, and we will come to you again within the discussions. So please, Professor Dawlat, take the floor.
Thank you, Yasser, for your introduction, your kind introduction. I'm very pleased to present Wesam, who is a very clever clinical pathologist. And if you can see, she's very clever. She's starting her meeting with a case. And this is the best attractive thing that can attract people to not to concentrate on the case. So thank you very much for giving me this session to moderate. And please start, Wesam.
One second, just please, before you start, Wesam, I would like to thank Dr. Rami Abu Bakr, our coordinator today,
yes,
for all of his work in CME chapter meetings and CME chapter activities, and regarding especially in this session. Thank you, Dr. Rami, and please, Professor Wesam, start your interesting lecture as usual.
Thank you very much, Yasser. Thank you very much, Dr. Dawlat. The pleasure is always mine. Well, thank you very much for the nice introduction and the nice words. I chose today to be all cases, case scenarios. Hopefully they follow a thread and highlighting the importance of having a biopsy in the setting of AKI, and what else could we be surprised with in this setting. I'm not going to be long. I chose only 4 cases. So we're going to start, but I have some, these cases, again, we should have some interaction. So I have some questions in the middle, and I hope that the audience would interact with me. So we'll start with our first case, and it's more or less a straightforward case. This was a female, 19 years old, presenting with hypertension, anuria, and serum creatinine of 14. Her ANA was positive, but double-stranded DNA was negative. C3 and C4 were normal. She has a negative virology, no relevant past medical history or family history that we know of, and her pelvic abdominal sonography showed grade 2 nephropathy. I know that these are very limited clinical data to nephrologists, but unfortunately, this is basically the data that we get, and this is the data that we use for diagnosis. So in brief, or out of this brief history, the patient actually does not have any more history than this, rather than she's only 19. This is her first presentation ever. She presented with hypertension, anuria, and serum creat of 14. There is absolutely no relevant medical history or family history. Her physical examination was basically, did not have anything else significant other than the renal condition. And as you see, her serology, she had ANA positive, but her double-stranded DNA was negative, and the complement was normal. And we don't have urine analysis. The patient was completely anuric. So what do you think we are looking at now? And a 19-year-old coming with a serum creat of 14. Is this a lupus nephritis? Is this an ANCA vasculitis? We don't have an ANCA. They did not do ANCA. Is it both? We know that some cases could have lupus and ANCA, or is it something else entirely? So quickly, if you can write on the chat, or if you want to open the mic, we can have your opinions. What do you think?
Actually, Wesam, it's you that should ask the nephrologist some more information about the case.
Okay, so what other information do we need to know?
She has no symptoms at all of arthritis, fever, skin rashes. Nothing was mentioned.
No skin rash. This was mentioned. She had no skin rash. I don't know about the fever. It was not but usually what's skipped and in the requests we consider it that it's negative except for asking about something else.
Right.
So
no risk infection.
the possibility.
Wesam, you received the answers on the chat. You can look for
it. I can see that. So some thinks that this is a lupus nephritis. Someone thinks that this is something else. There's thinks that this is both lupus and ANCA. Also, Radwa thinks that this is both lupus and ANCA. Someone thinks that this is small vessel vasculitis versus just an acute tubular injury, which is of course valid. We don't have urine analysis, so we don't know whether the patient has proteinuria or hematuria or not. Others favor
exactly. The urine analysis is very important here.
Exactly, but the patient is anuric.
Completely anuric. No history of infection, throat infection, any infection?
No upper respiratory tract infection or anything. We do get some brief history of the patients when they come, or of their relatives or their parents. We don't always recommend on the request, depend on the request, because as you see the request, and we also ask for the full labs of the patient. So we ask for the labs from the patient, we interrogate the patient and the patient's family for any extra history, because usually the requests are defective. But this patient really did not have that much history to go on. So I think they are all valid answers. Okay, Hazem said that it's a TMA, which is a possibility. We don't have any idea whether she has any form of hemolysis or not, but again, TMA with the serum creat of 14 and completely anuric, I would not put it the first differential diagnosis. Both, everybody was so interested of both. So this will take us to the second question. Is it okay to diagnose lupus nephritis with just an ANA positive? And if this is lupus nephritis, then we are expecting that this is active lupus nephritis, I think. So would you accept this diagnosis with a C3, a normal C3 and C4?
Yes, normal complement is against activity.
Exactly, this is what I'm saying. And if we're considering that this could be lupus nephritis, then it has to be active lupus.
Well, actually, what is with lupus, clinically speaking?
Only ANA positive.
She's anuric. She's in acute renal failure.
Exactly, which is, thank you, which is totally against lupus activity. Okay, let's look at the biopsy.
The urine should be very important here.
Dr. Manal Deeb is asking, is she pregnant? Or a history of pregnancy?
No, she's not.
No. Okay.
No, she's not married, she's single. Okay, let's see the biopsy. Okay, what do you see here in the biopsy? This is a medium power, and you can see glomeruli exactly with very florid crescents, not only crescents. They are all necrotizing crescents. And what's interesting in this crescents, they are almost all of the same age. When we say same age crescents, means that we don't have fibrocellular crescents, we don't have fibrous crescents, which what you usually see in a crescentic biopsy. But when you see a biopsy with all the crescents more or less the same age, this is not fibrosis or sclerosis, this is extensive necrosis. So you have large cell crescents, almost ruptured the glomerular basement membrane and bulging into the tubulointerstitium, and with necrosis. This is necrosis in the crescent, and we do not consider it necrosis in the tuft. Again, as you can see here, this is silver stain. This is crescents collapsing, completely collapsing the tuft. You can see that we have here some endocapillary hypercellularity and some proliferation, nothing else significant. And all of this pink material is the necrosis within the crescent, as well as some inflammatory cells and karyopyxis, inflammatory here as well, again. And this is a totally collapsed tuft, starting to have an area of sclerosis, again, completely collapsed with the crescents. Good. So, do you think this is diagnostic? Is this a diagnosis? Did we get to a diagnosis of this patient? Now, this patient had 100% crescents. Was this diagnostic, or do we need further tests? In other words, do we need to go on, have immuno and
Yes.
an EM maybe? Yes, so let's see her immuno results. So she was positive. She had positive IgG on the glomerular basement membrane and positive C3. So this histological pattern is of a lupus GN class 4 with 100% crescents. Now we can easily exclude ANCA because we have an immune complex mediated glomerulonephritis. Or is this an idiopathic immune complex mediated GN with 100% crescents? Or is this a C3 glomerulonephritis with 100% crescents? Or is it what you call a crescentic GN? Or is it anti-GBM disease? Let's hear what you think.
But C3GN would present with a mesangiocapillary or membranoproliferative pattern.
No, C3GN can present with anything.
Is
It can
what?
present with C3GN can present with a different with all types of patterns. It can present with mesangial proliferation, with MPGN, with focal segmental glomerulosclerosis, with proliferative GN, exactly like infection.
Wesam, can you show us the slides, please? One is asking, Dr. Mahmoud Sheikh is asking if it linear depositions.
Good question. And the answer is, without showing you the slides again, you cannot say linear or granular. This is immunoperoxidase, not immunofluorescence. So a linear deposits are based, this description is basically for immunofluorescence studies, not immunohistochemistry. So let's take them one by one. Idiopathic immune complex mediated with 100% crescents is a possibility. Lupus GN class 4 with 100% crescents. I have never seen a lupus activity with 100% crescents. So 100% crescents is basically against the lupus activity. And again, as we said, she does not have any other symptoms of lupus. So, and her complement is normal. C3GN. Now, if you look back at the picture, I'll try to go back. It's not working. Can only, let me see. Yes, from here. Okay, you can see that the IgG is even stronger than the C3. Actually, the C3 seems a bit non-specific and weak. And of this brown color, it's more of endothelium, but the IgG is really strong. So this is definitely against the diagnostic criteria of C3GN, where we have to have a dominant C3 deposits. And if we have any other immunoglobulin deposit, it has to be negative by 2. Is the diagnosis called crescentic GN. We don't have a diagnosis or a disease called crescentic GN. This is a pattern of disease, exactly like the clinical correspondent to it, which is rapidly progressive glomerulonephritis. Now, these are not diseases. So this is a clinical term, and this is a pathological term, just which describes the process. So in a patient with 100% crescents, we need to know the disease. A lot of people favors anti-GBM. Dr. Ismail, Dr. Hisham says, sure, anti-GBM. Yes, exactly. Thank you, Dr. Hisham. Why anti-GBM? Because these are same age crescents. Before we proceed to the diagnosis, I just want to tell you that we also favor our diagnosis based on the relative frequency of crescent formation in different forms of glomerulonephritis. So as you can see from this graph, that in lupus GN, you hardly get more than a 60% crescents, and this is the maximum that you can get. So when we have more than this in lupus biopsy, then there is something else going on. This is if I'm sure that the patient is lupus. And if we're not sure that the patient is lupus, then this definitely is not lupus. So a biopsy which has 100% crescents is definitely not lupus. Lupus does not do this. As you can see, IgA vasculitis also gives you an average of 60 to 70% crescents. In C3GN, you do have crescents, but again, not 100% crescents. and so on in all types of glomerulonephritis or different diseases which can present with crescents. The percentages of crescents would vary from 20% up to maximum 60%, except for the first two entities, where anti-GBM and ANCA vasculitis. And this is where expected that you would have biopsies with more than 50% crescents, actually around 100% or 90% crescents. And this was my diagnosis, that this is a proliferative GN with 100% crescents compatible with small vessel vasculitis, most probably anti-GBM disease. And this is for serological correlation. Why? Because as Dr. Mahmoud Sheikh asked, the linear pattern of IgG, as you can see here, is on immunofluorescence, and we cannot establish it on immunoperoxidase, but definitely the biopsy was highly suggestive of GBM. As Dr. Hisham mentioned, same age crescents, very large florid necrotizing crescents rupturing the glomerular basement membranes, patient's age, the lack of any other symptoms all suggests anti-GBM. So the message of this case is that not every DNA positive case is lupus.
Finished, Wesam?
Yes, I finished the first case.
Okay, thank you so much. Professor Hisham Said wants to comment, please.
Yes, thank you very much. I like the graphs. It's an excellent graph, and I would like to share to our colleagues that the percent of crescent in each disease. I think the scenario of your case depend on 100% of all are the same age, and this is unlikely to happen away from anti-glomerular basement membrane disease. Either it is limited form or it is a full-blown picture of Goodpasture.
Yes, very true.
Thank you very much.
Thank you, Dr. Hisham. Let's take the second case.
Okay. Professor Dawlat, do you have a comment before we proceed?
Not really, but I'm very happy that the importance of the percentage of the crescents is that diagnostic. This is really very interesting.
Yeah. Yes, of course. It does help a lot to have. I don't know what's happening. It does help.
Again, ANA is not specific for lupus at all. It can happen in many other situations.
And yes, and then when you get a very acute biopsy with crescents, then they think, and she's ANA positive, and with the criteria of the Rheumatological Association for Lupus diagnosis, that if you have criteria of in the biopsy consistent with lupus, then you can easily diagnose this as lupus nephritis. And this is the whole point. Now, be careful. Lupus will not give you acute renal failure. Lupus will not. I want to ask you, how many cases have you seen of active lupus with acute renal failure this way? This is clinical wise, it does not say that this is lupus activity. And in the biopsy as well, in spite of the presence of crescents.
All right.
Thank you, Sam. It was very interesting for me, this the percent of crescents for diagnosis. But it does it work in all cases, or this
most of the time? It's not for diagnosis, but it makes you direct your thinking, so you know. But most of the time, yes. Yeah, most of the time.
Thank you so much.
And if it doesn't work, then usually if I have a biopsy of lupus with 60% crescents, for example, then I'm guessing that this is not, it's not a well-represented biopsy. So we also balance it with the number of glomeruli that we have and so on. But it helps you to know that this is not what you're dealing with. Now, this is a male patient, 28 years old, presenting with unexplained rise of serum creatinine, 4.8, and proteinuria, 3.8 grams. So we have nephrotic proteinuria, and I think this patient also had low serum albumin. I'm sorry, the data, but I was in a hurry presenting it up, so I did not put all the data. So this patient had a full-blown nephrotic syndrome and also acute kidney injury, a serum creat 4.8. Not known hypertensive or diabetic. Again, his ANA was borderline, C379, C410. He had a normal CBC and a negative virology. So this was basically the data, and then we'll see. Yes. So
the urine is very important.
The urine is very important. I think he had bland
Active
urine
or a bland urine.
And they didn't mention. So we have to go based on both, if he has active urine or if he has bland urine.
He's not hypertensive at the moment. He's not hypertensive.
It was not mentioned. But I think he was, but it was not mentioned. He's not known. This is what was written. Usually when you get a sentence of he's not known diabetic or hypertensive, then that means that they discovered that the patient became hypertensive or diabetic. Or they did not check it yet.
Yes.
So again,
I think what is not mentioned is negative.
Yeah, we all assume so. And then we ask for specific things. If the diagnosis is not straightforward, and I have to say,
Okay.
we also have the advantage of looking at the biopsy. So if the biopsy is diagnostic, fine. If we have a differential diagnosis and you need to favor something else, then we dig more for more clinical data. So again, is the lupus nephritis? Is it a membranous GN? Is it an FSGS? Is it an acute TI on top of chronic kidney disease for any reason? Or is it something else entirely?
Now, given the clinical picture that he has no arthritis, he has no fever, he has no rash, lupus nephritis can be put on the side. FSGS, he should be hypertensive, and his urine should be an active urine. Membranous is a possibility, of course. Acute on top of chronic, you said he was never hypertensive and he was normal before. Looks more to be more
So a lot
membranous.
Yeah, we have more. There is something else. Yes, but why does he have a creatinine of almost 5? His creatinine is 4.8. Why IgA nephropathy? It's not common for IgA nephropathy to come to present with a nephrotic syndrome. And then why the high creatinine? We can assume that he has either a membranous GN or an FSGS, as was mentioned, plus something else acute, like tubular injury, for example, or something else going.
No drug history at all?
IgA could be with any presentation, but any presentation with IgA is not going to give me nephrotic syndrome. I mean, you get a nephrotic range proteinuria with IgA when it presents with FSGS. And usually you get nephrotic range proteinuria. And if this is an IgA vasculitis, then it's not going to be, the patient isn't going to be that proteinuric. Okay, Dr. Mahmoud al-Sheikh saying collapsing makes sense. Tubular injury would present with higher proteinuria range? No. Tubular injury is going to be an add-on finding together with something which is going with the proteinuria. So the patient could have tubular injury and a membranous GN or tubular injury and FSGS. We see this all the time. Okay, let's look at the biopsy. Now, what do we have here? Again, we have collapsed tuft. We have extracapillary hypercellularity, as you can see. And another one here. Show you higher power. And collapsed tuft with a lot of epithelial cells.
Yes.
Capillary hypercellularity. This looks like FSGS. So
FSGS,
is it FSGS or is it crescent?
Cellular type.
Is this a crescent or pseudocrescent? It's extracapillary, so you cannot call it cellular. What do you think? Cellular type is the FSGS itself.
It's definitely cellular.
Everybody is good. Yes, but cellular refers to cellularity in the lesion of the segmental. This is collapsing.
This is collapsing.
This is collapsing, yes. And as you can see, all of these are just podocytes. And they do look sometimes like true crescents. So again, you have a collapsed tuft, like in the previous case, and you have a lot of hypercellularity. But this time, all the cells are only epithelial cells. You have no necrosis, you hardly have any inflammatory cells, but it's not that straightforward always in biopsies. And in a patient coming, this biopsy was a consultation case, and this patient was diagnosed as a crescentic GN. So, which he was not. He was just a collapsing FSGS. This was his EM, and as you can see, he had diffuse podocytopathy with microvillus transformation. This is on the right part of the collapsed tuft with early sclerosis. So his immuno was completely negative, and the diagnosis was collapsing glomerulopathy as part of primary FSGS. So this is just, again, to be aware the collapsing glomerulopathy as a variant of FSGS patients can present with acute renal failure and nephrotic proteinuria. And in that scenario, and these crescents could be misinterpreted as true crescents when they are pseudocrescents, and these patients are completely a different diagnosis, and they are just a variant of FSGS. Of course, in these patients as well, in spite of the podocytopathy, viral infections has to be excluded. So you have to exclude HIV. Of course, when at the current era, we have to exclude COVID because COVID causes a lot of collapsing glomerulopathy, and we stopped being focused on COVID, so it's not mentioned in the requests anymore. And all what's mentioned is an upper respiratory tract infection, that this patient had history of an upper respiratory tract infection, and so on. What I mean is that there are so many other causes of collapsing glomerulopathy rather than this is just being a variant of FSGS. Okay.
Thank you, Sam. Professor Saeed Khamis has a comment, please.
Yes,
Thank you, Professor.
Yes,
thank you,
and drugs, of course, heroin and cocaine. Yes, of course, they also cause collapsing glomerulopathy. Definitely. Dr. Saeed, تفضل.
Okay, thank you so much, Professor Wesam, for this elegant presentation. I have no comment on this case. I have just one comment on the previous case, first case. Even the serology can be negative for anti-GBM in the atypical form. So we cannot rule out even if it is negative. So I will rely on the further management or the immediate management, I mean, on the biopsy, and I will start aggressively to treat this patient. That's my opinion.
Okay, excellent comment. But as far as I know, and I stand corrected, of course, the atypical forms of anti-GBM does not present with 100% crescents. They do not present like the typical anti-GBM. They rather has a different pathology picture. So they are very difficult to diagnose. But they can be anti-GBM.
Yeah, but I mean, if it is negative, it cannot be ruled out. I mean, there is what's called the atypical form.
Yes, definitely. Yeah, these patients should be investigated in relation to collapsing glomerulopathy. To answer the question, yes, they should be investigated, but mainly for viral infections. Collapsing glomerulopathy.
No, I don't mean this case, Professor Wesam. I'm talking about the first case.
Yes, Dr. Saeed, noted. Very good comment. Thank you very much.
Okay. Shukran.
It was a comment on the chat from Dr. Ayara, and Wesam answered. Wesam answered.
Collapsing glomerulopathy is mainly caused by viruses.
Oh, yeah. Okay. Shukran, Dr. Wesam.
PSOL clinical, if it was anti-GBM with creatinine 14, it will be irreversible with no role of any treatment. I think this seems to be a comment, not a question. Okay. You guys know better. You're the clinicians. So we can move on. Okay, this is a female, 47 years old, who presented with a serum creatinine of basically 3.56 from 2.9, or that was her first presentation. Her serum creatinine was 2.9, and then it became 3.56 in a short period of time, 2 weeks. She had a protein creatinine ratio of 858 milligram and hematuria 30 to 40 per hyperfeet. She is non-diabetic for 3 years, hypertensive for 5 years. She had a nasal mass, which was surgically removed, and she was still waiting for the pathology results. Her hemoglobin was 6.3 and was corrected to 10. She had TLC of 10.3 and platelets 525. Ferritin more than 1,000, ESR 120, ANA negative, double-stranded DNA negative, C3 and C4 normal, and negative virology. So again, this time a more or less an acute kidney injury, not renal failure, with hematuria, with non-nephrotic range proteinuria, with a history of diabetes and hypertension, and marked anemia of hemoglobin 6.3. So our differential diagnosis. Is this a diabetic kidney disease? Is it an acute ATI or TIN? Is it amyloidosis? This nasal mass, it's probably malignant. So is this a paraneoplastic syndrome? Low hemoglobin, is it a TMA? or is it, again, something else entirely? Yes, sir. Can you please take over the answers in the chat till I just plug in the power in my computer, because I'm gonna lose power.
Okay. Wegener, Anka, GPA. These are two. GPA, Wegener, something related to hematological malignancy, and it doesn't specify. Mostly GPA answers for the GPA. And Wegener. These are the most answers, Wesam.
Okay. So everybody is in favor of vasculitis.
Yes, yes, they are working with vasculitis. Only one answer for the paraneoplastic mass, and didn't for the mass, and didn't specify specific diagnosis. A pathological answer from about granulomatosis. Yes, again, granulomatosis with polyangiitis. Granulomatosis, polyangiitis, again, GPA.
Yeah, because we stopped using the terms Wegener's and okay. So it is oh yeah. All right. So seems everybody is right. So why do we need a biopsy? So here you go. This was the glomeruli of this patient, and now you can see this is an H&E. On the left, it has segmental tuft necrosis. On the right, this is the trichrome, and it stains the necrosis red. So as you can see here, again, this is a glomerulus with a segmental tuft necrosis as well. And our crescents, again, on the left, you have in the PES, and these are necrotizing crescents. And on the right, this is silver, again, a collapsed tuft with a large, nice necrotizing crescent. Some of the glomeruli of these patients looked like this. Does anyone know what are these?
Can you answer, please? If you have anyone having an answer.
Anybody has an idea?
Huh?
The pathologists who are attending.
Yes,
Anybody
if you want
the
pathologists are not allowed.
know.
Pathologists are not allowed.
Exactly, pathologists are not allowed.
Pathologists are not allowed.
Okay, so yes, these are giant cells.
And cells.
So you can see here, yeah, this is what we call giant cells. So these ones, these large cells with multinucleated, so we have multinucleated giant cells, and this is a granuloma. So this is a granulomatous reaction. This is a granuloma with numerous giant cells. Again, here is another granuloma with a lot of, with what we call epithelial cells, some necrosis. What about these red balls? These red balls are actually sclerosed glomeruli, which were completely consumed by the process and with the necrosis, and they healed. And this is classical healing of a granulomatous vasculitis. These granulomas are mainly tubulointerstitial. This is why we always have ANCA vasculitis within the differential diagnosis of the granulomatous TIM.
What about the interstitium, Wesam? It's full of cells.
Yes, of course, it has an inflammatory. I was just saying that this granulomatous reaction is basically from the interstitium. So you get a lot, and in any acute GN process, you're going to have an interstitial inflammation, especially if it's a vasculitis. Let me show you the rest of the biopsy, but this is a nice case.
From Dr. Ahmed Wesam asking about macrophage histolymphocytosis.
No.
No.
Yes, no, not sarcoidosis. Sarcoidosis is not going to give you crescents nor segmental necrosis. This is what we're saying, that we have to take everything within context. Now, this very red material was an arterial wall. This is a completely necrotized artery with necrosis, again surrounded by a large granuloma, as you can see here. This is a large granuloma. I'll show you more pictures. What is left of another artery on the left. All of this pink material is the necrosis in the silver, and here you have the epithelioid histiocytes. And on the right, this is the PES, and necrosis stains pale with PES, so you can see a lot of necrosis here. And again, what is left of this granuloma. And I want to tell you that it's not common that we see such frank granulomas with giant cells in granulomatosis with polyangiitis, and that you have to think about it even if you have just crescents and segmental tuft necrosis. This is ANCA vasculitis, and it can be anything. What was interesting, this patient also was the number of eosinophils. She had a lot of eosinophils surrounding the granulomas were full of eosinophils as well. So no, this is not sarcoidosis, does not give you necrotizing arthritis, nor necrotizing glomerulonephritis, no crescents. So this is simply granulomatous vasculitis, post-immune. Her immune was completely negative, the IgG and C3. And I'm reminding you with the same old vasculature, quite old right now in 2012, but it's still the same nomenclature that we use. And that this is ANCA-associated small vessel vasculitis, and that this is eosinophilic granulomatosis with polyangiitis. So this is the diagnosis of this patient, that this is a focal necrotizing GN with 40% crescents, although this is ANCA, and necrotizing arthritis compatible with post-immune granulomatous polyangiitis with eosinophils, or eosinophilic granulomatosis. Church-Strauss granulomatosis, the term that we don't use anymore. So I had this case to show you that it's not always the percentage of crescents, but that we integrate all the findings that we see in the biopsy together. So if you have a granuloma in the tubular interstitium, we come up with the differential diagnosis, and then you have to fit all the other biopsy findings. So no, if I have a granuloma, I don't think a granuloma with necrosis, I don't consider that this is going to be sarcoid or tuberculosis, not this type of necrosis, not when you have necrosis of vasculature. I don't know whether she had history of asthma or not. This is the history we had. And again, it's suggestive. She could be Wegener's. I just had a lot of eosinophils in the biopsy, and this has to be mentioned.
Yes. What about the renal mass, the nasal mass?
Nasal mass.
You said she had
the nasal mass. Yes, the nasal mass turned to be an allergic sinusitis, a severe allergic sinusitis with necrosis. It also took to be vasculitis. So she had the vasculitis also within her nasal cavity.
Or another a granulomatous lesion or something.
No, it's not another granulomatous lesion. She had the same granulomatous lesion. Not always that you have, yes, it occurs in long-standing asthma, but not always that the patients are properly diagnosed as being asthmatic, by the way. And I have seen cases like this, and we had to go back and ask the patient, and then all the pieces start to fall in together. And as I said, I might be wrong. It just could be just Wegener's, by the way.
Can drugs have a role in this granuloma with this pathological picture with the plenty of eosinophils?
No, no. Vasculitis gives you eosinophils. This is why I say it carries a differential diagnosis. And by the way, usually this is why we usually say just ANCA vasculitis, because we don't always can tell which ones are they exactly. They are not always that straightforward to differentiate from each other, by the way. And I have cases which turn to be Wegener's when they only had crescents and in the biopsy, and segmental tuft necrosis did not have any evidence of granulomas. So you don't always get this classic picture.
Okay, thank you.
It's not always that straightforward. Yeah.
Thank you, Professor Hisham Said. Please.
Can I thank you very much, Professor. I've never been happier than today for your very elegant slides. Really, I am enjoying that. Just a small question. Does the infiltrating type of leukocytes can differentiate between different etiology, acute and chronic? To my knowledge, no. And correct me, please.
No. What do you mean by acute versus chronic?
If you see, for example, too much lymphocytes or too much neutrophils or too much eosinophils, does this yielding for a specific diagnosis?
Only neutrophils. Only the neutrophils.
Yeah, so if you have an extensive...
Eosinophils are non-specific cells.
So if you find much eosinophils in your biopsy, does it make sense for a diagnosis of Church-Strauss or any other diagnosis? To my knowledge, no.
By the
No,
way, this is a
because
question
what
from
I'm
Dr.
saying,
Manali.
any vasculitis is going to have eosinophils in it. If the eosinophils a bit more, we suggest that it could be Church-Strauss. It's just a suggestion.
Yes, so it
And
is
this
not
is
a master to
the
find that.
No,
Okay, that's to correct my knowledge that I know that. Thank you very much.
yeah, eosinophil is a non-specific cell.
Okay, thank you.
Thank you.
Okay, thank you, Sam. Go ahead, please.
Okay, now this is my last case.
Okay.
But it's a bit of a long case. So this is a 65-year-old female. This patient, she's diabetic and has controlled hypertension. She's known chronic kidney disease and on baseline creatinine 1.8 for 2.5 years. However, within 3 months, she developed rapid deterioration of her kidney functions from 1.8 to 3 to 4 to 5.7. She also developed an nephrotic range proteinuria 6.2 grams. Her fundus examination showed no evidence of retinopathy. She had negative immunology and virology. Her serum protein electrophoresis was normal, and her Burns-Jones urine was negative. So diabetic, presenting with a rapidly deteriorating renal function from 1.8 to 5.7, and a nephrotic range proteinuria 6.2 grams. Patient refused biopsy and fistula, which was the advice of the clinician, disappeared for 3 weeks and returned with a serum creatinine of 8, upon which urgent dialysis was performed. Her vascular access got infected, so she received antibiotics, and renal biopsy was performed. So what are we dealing with here? What do you think? Is this diabetic kidney disease? Is this an infection-related GN? Is it both? It seems she had already something going on with her kidneys before she had any form of an infection. Is this amyloidosis? Is it diabetic kidney disease and amyloid? Is it end-stage diabetic kidney disease and the kidney was just decompensating? Or is it something else? Or is it all of them?
Was duration of creatinine after she got an infected fistula?
No, it was an infected hooker, as I understand, and it was a simple infection, not the fistula itself.
When she came back with a creatinine of 8, was this after the fistula was infected?
No, before. No, she came back with a creatinine of 8, so she required dialysis. So she had
yes.
a direct vascular access, and this is what was infected, not the fistula.
Okay. So infection-related GN here is not on the #1 list, yeah.
No.
And why do you think she has amyloidosis? Why?
It's a possibility. If she has a lect amyloid, then this is why her serum creatinine is deteriorating fast, because it's depositing in the tubulointerstitium, and it would explain the nephrotic range proteinuria with the diabetes. If it's not lect, if she has AL amyloidosis, then she is going to deteriorate on both levels. She's going to have nephrotic range proteinuria, and if it's depositing in the tubular cortex.
Her proteinuria is not that massive. It's how much?
6.2.
Okay. 1 and 4. She has a baseline of diabetic kidney disease and something acute.
Her baseline creatinine was 1.8, and then within 3 months it jumped to 8.
Something acute happened, and she's hypertensive. Okay.
Exactly. So we have a lot of answers here. Dr. Hisham asked for immunofixation, of course. Thank you, because SPAP is non-specific. Khaled Abu Zaid said RPGN, very good. Of course, she is an RPGN. Manel said plasma cell dyscrasia in spite of the negative SPAP and urine protein and Burns-Jones negative. Someone suggested that it could be membranous. Someone else
amyloid lect.
it could be membranous.
Amyloid lect was suggested also.
Yes, membranous again. Okay, fine. Membranous would explain the 6.2 proteinuria. What would explain the deterioration of serum creatinine from 1.8 to 8? Amyloidosis, something else.
Did she take any drugs? Was she on ACE inhibitors? Uh,
I don't know that much details, but would ACE inhibitors get her from 1.8 to 8?
no, I mean, definitely there's a factor on top of the baseline of the diabetic nephropathy. What is this factor?
Definitely, yes.
Did she receive any antibiotic, any nephrotoxic agent?
Her clinician have excluded all of this when she went to him with a creatinine and 5.6. This is why he requested the biopsy, and he saw that she is a requested fistula because she had rapidly deteriorating creatinine, and the patient refused both.
And the
So
sonar is not showing anything, any clue, the ultrasound?
No, just the usual symptoms of grade 2 nephropathy. FSGS.
The urine is an active urine. Definitely.
Yes, it is an active urine. Yes.
Yeah.
We can think LECT, we can think AL amyloid.
Dr. Ihab, light chain.
LECT is not going to be alone because
Ah.
LECT does not give you that much proteinuria. So in this patient, it's very difficult to pinpoint it to a single disease entity, actually. So let's see the biopsy and then see what you think. We will discuss again. So this is her biopsy. What are we seeing here? This is a classic straightforward nodular glomerulosclerosis.
Okay.
So yes, this is the PES. So we have nodular glomerulosclerosis here, but also the capillaries had a lot of leukocytes, and this was a crescent. And this is large nodules, PES positive, and with the silver, you can see here again, we had crescents here, and we had all of these nodules, which is classically nodular glomerulosclerosis. We have marked arteriolar hyalinosis, as you can see with this arteriole. I'm going to show you her vessels. Her vessels, again, she had some endothelial swelling. This is extensive hyalinosis, again, extensive hyalinosis, and very thickened blood vessels, actually. And I did think in the beginning that she could have amyloid deposits within them, but her congruent was completely negative, so amyloidosis was out of the story. So this was her immuno, her IgE and IgG were negative, and her C3 was positive, mainly mesangial. So what do you think now? So based on this histological picture, do we have diabetic nodular glomerulosclerosis only? Do we have infection-related glomerulonephritis with crescents? Do we have both? Do you need to do any further for this patient?
What is with infection?
The capillary hypercellularity and the crescents.
And the crescents?
Yeah, and the crescents. What would explain the crescents? And she did have some segmental endocapillary hypercellularity, and it's common in diabetics, especially if it's top of a diabetic glomerular disease, that it's not very florid and they are usually subtle.
We don't have immunofluorescence, right?
We have immunoperoxidase. Her IgE and IgG are negative, and her C3 is positive.
Negative IgE.
And she has C3, so she does have an infection-related GM. The C3 is not it's not a pattern of membranous or anything else. This is C3. This is mainly mesangial C3. She goes with an infection. She did not have anything else. And her IgE and IgG were negative. And so this excludes other immune complex mediated glomerulonephritis as well. She's not membranous. She's not fibrillary. She's not anything. Are we satisfied with this diagnosis? What is EM going to tell us? The person who wrote EM, tell me, what is EM going to add in this patient? What are you looking to look for with EM? She has EM, by the way. This is a very recent case of mine. I only this case a couple of days ago.
Tell your answer. I think this is the correct one. Don't be shy. I think this is the correct one.
Yeah, so I just had it. So we don't have EM so far, but no, seriously, what will EM add? That we have thick GBM. What do you mean? Thick GBM as in diabetes? Yes, fine. And humps. I know that I feel that everybody's very optimistic. Yes, we would be very lucky if we had some humps and this type of infection on top of nodular glomerulosclerosis. No, we don't call this C3 glomerulopathy. This is maybe But interestingly enough, if she does have C3 glomerulopathy, then what are we going to consider in this patient? She's 67. We need serology of what, Dr. Hisham? Site and nature of the deposits. Now, nature of the deposits is by immuno. And site of the deposits is also obvious by the immuno. Her C3 is very obvious in the mesangium. Malignancy. What type of malignancy? If we have a C3, okay. Okay, we're not done. So you guys are satisfied with this? I was not satisfied with this. So we proceeded to do kappa and lambda, and we do kappa and lambda routine for any nodular glomerulosclerosis, and also for any patients who is over 50. So we perform kappa and lambda routinely because you really can be surprised, as you can see here. So on the left, this is the patient's lambda, and on the right, this was her kappa. And all of you was right because this was actually the first suspicion we all had. This patient is actually monoclonal. You can see completely negative lambda, and this is kappa heavily deposited in her arteries. And this is what I detected in the biopsy early on, that there was something within her blood vessels. And you can see the tubular basement membranes strongly. And this is the same glomerulus with the crescent stained with kappa. And you can see here on the right, again, her arteries all full with kappa deposits. And you can see here kappa deposits by, tubular basement membrane deposits by the kappa. So her diagnosis was actually not diabetes. This is light chain immunoglobulin deposition disease. And I'm actually waiting for her EM to see whether she has also diabetes or not. Kappa type associated with an infection-related GN with 15% she had infection. This does not exclude the infection, but this time the infection, this was not her main diagnosis. Her main diagnosis is light chain immunoglobulin deposition disease. She already had global glomerulosclerosis 50%, which says that this patient, her original renal insult is diabetes. And she must have had an ongoing diabetic kidney disease because LCDD is more or less, it's not a very acute insult, but it's not going to go on for years. So, and as with her renal presentation, that she developed the light chain disease only 4 months or 5 months back. She already had glomerulosclerosis 50% and moderate IFTA 40% and marked arterial hyalinosis, which are all findings more inconsistency with diabetes. So this patient has, as I told you in the differential diagnosis, like she could have it all. So she does have diabetic kidney disease. She developed light chain immunoglobulin deposition disease on top of her diabetic kidney disease, which caused her acute deterioration of renal function and the proteinuria. And then she is an immunocompromised patient. She is a malignant patient, and she had an infection, which also got manifested in her kidneys with the crescents and the infection-related GM. And that's it.
Thank you. Thank you, Sam. Professor Saeed Khamis, please.
Okay, thank you, Professor Wesam, for this elegant presentation as a whole, and especially the last case. And I talked to Dr. Hisham and Dr. Yasser before regarding, I don't know, it is overdiagnosis or it is actually it is more prevalent nowadays, this protonemic or whatever the nomenclature. I mean, the multiple myeloma, the light chain disease, or whatever. It is became, I cannot say very common, but it is a rather more common than before. For me, for example, we have limited number of inpatient beds, almost 25 beds, but we can say at least once or twice monthly we face such cases. I don't know, is it overdiagnosis or just it became more prevalent? Second message, as you said, is don't rule out these illness by the serum protein electrophoresis or the negative Bence-Jones protein, and we should proceed more and more in depth regarding the renal biopsy. And thank you so much.
You're welcome, Dr. Said, and I totally agree. We're seeing it more when I was training, and when I was a resident and training, and I'm not going to say for how long was that, how many years, but when we had a case of multiple myeloma, then this was a case where all of us, the juniors, were gathered so that we can see it. So we used to see cost, and when an interesting case presentation, a case of cost nephropathy was presented in it. Now it's routine daily work. And even when I was considering the cases I'm going to present today, one of my assistants told me, okay, we have a very nice case of light chain cost nephropathy. And I said, okay, it's not as interesting as it was before to present a light chain cost nephropathy. So definitely multiple myeloma is changing its face for more than 10 years now. And we have seen completely different age presentation, different presentations, and much more patients than what was before.
Thank you so
Thank
much.
you, Sam. Thank you. Very interesting case. And it shows that you are indispensable. And,
Thank you very much.
and that we should not take it for granted that the patient is diabetic and just agree that this is end-stage diabetic disease. So it's your perseverance after her you found out what was wrong. But I think a clinical picture should be more rich than that. It's we are diagnosing.
ما تنجحيهمش في الزمالة بلد دم بيكتبوا ريكوستات عاملة كده.
It's our fault. It's the nephrology fault.
Yes, I know. This is what I'm saying. هم بتوع nephrology
this is what we call diagnosis. You know, this is what we call diagnosis at the end of the bed. We read the pathology and then we diagnose the case. I'm sure this lady should have had electrophoresis, serum electrophoresis, urine electrophoresis. All this should be in her file. But thank you very much anyway. You highlighted a very important topic. Thank you very much.
Thank you.
Thank you very much, Wesam. But I want to comment on two things. In the last case, we must return to the basic. When in the biopsy of you, there was nodular glomerulosclerosis for differential diagnosis. It is diabetic or light chain disease. Okay. يعني هي patient has no retinopathy, but the differential diagnosis diabetic kidney disease or light chain disease, as Dr. Hisham said. The second thing, or second comment about if there is acute kidney injury unexplained, we must think of plasma cell, يعني multiple myeloma or light chain disease. Okay. Many thanks, Wesam.
You're welcome, Manil. Thank you. Thank you for attending.
Thank you so much, Sam. I don't have any more comments and no more questions. All asked their questions and commented at time.
Can I have a comment, Dr. Yasser?
Please, Professor Hisham, please.
Thank you again, Dr. Wesam. Now we are routinely testing for immunofixation for all patients above 50 with rapid decline of renal function and with such a presentation. It is not a simple case of acute kidney injury. It is a case of progressive kidney disease not related to diabetes, even on the background. So our approach usually, even we had seen a lot of patients, even 30s or 40 years with free light chain and only diagnosed by immunofixation and biopsy. I have a question here, maybe of clinical pathological value. Do you think that if you don't find a biopsy, a cost nephropathy, can we explain the rapid decline in renal function? It's important to understand the nature, because the therapy will differ in both direction, especially if we are treating the patient in hemodialysis. This will have a specific type of hemodialysis to remove the kappa and lambda. So,
yeah, of course, definitely. But this is a very important question. Thank you very much, Dr. Hisham. This is not cost nephropathy. This is what patient had. This is MIDT, and this also answers the question of always, why should we biopsy the patient if we know that the patient has myeloma, or if we know that the patient is monoclonal gammopathy? Because the patient has different things. Myeloma presents with different
yes.
And they have completely different prognoses. So cost nephropathy, as you're saying, a cost nephropathy is potentially a reversible condition, which
Sure.
you need to recover the renal function to be able to manage the patient with chemotherapy, maybe arrange for stem cell transplantation, and all of it. You need the kidneys. You need good kidneys. Patients who are on dialysis, they don't have this option. On the other hand, MIDD, or like the ones I showed you, or LCDD, which is light chain deposition disease, it deposits within the tubular epithelium, and this is why the patients have renal failure. And it's actually a chronic thing. These patients hardly ever improve. And as it deposits within the tubular basement membranes, it deposits also within the glomerular basement membranes. So this is why patients have heavy proteinuria and they have a renal failure. It's because of the light chain deposits within the tubular basement membrane. And as the disease proceeds, you find these light chain deposits also in the interstitium, almost wiping the interstitium out. And you find these large batches of batches of these light chains already deposited in the kidney, mimicking amyloid deposits, but they are not amyloid, they are light chain deposits.
Sure.
So
Thank you very much.
It makes a hell of a difference, yes. And of course, amyloidosis is the worst one, worst prognosis.
Thank you, Sam.
Thank you.
Professor Mohammed Abdelbari, لو سمحت. Professor Mohammed Abdelbari wants to comment, please. Unmute yourself.
اهلا دكتور ياسر، شكرا جدا دكتور وسام، بس للاسف شديد ان انا دخلت في الاخر فحظ كان فكري ان الساعه 10.
لا
معلش انا اسف جدا، ما كانش ليا نصيب ان انا اسمعها، بس ان شاء الله اسمعها مسجله ان شاء الله.
ان شاء الله.
شكرا دكتور وسام، وشكرا دكتوره دولت، وسعيد جدا بسماع صوت دكتور هشام. الحمد لله على السلامه. شكرا.
دكتور رامي أبو بكر, our coordinator today wants to comment, please.
Thanks, Dr. Wesam, for this elegant presentation as usual. And I have a question, which is usually a fight between pathologist and the nephrologist regarding starting treatment before biopsy. So sometimes we have a debate. A patient lupus came with active sediment and rapidly progressive picture with rapid deteriorating in kidney function, and some nephrologists prefer to do biopsy before starting treatment, and sometimes go for starting cyclophosphamide, and after starting cyclophosphamide, a patient not improving, asking about kidney biopsy. What is the implantation of kidney biopsy? Already patient started treatment, so which usually will not, it will, even the patient if presented with class 1 or class 2 after treatment, we will have a debate to stop cyclophosphamide or downgrade the treatment because already this pathology changed by started of medication. What is your opinion about this point?
Well, my opinion is, I'm sure you're expecting it. So number one, you have no clue whether the patient had gone into a class transition or not. We have enough evidence now to know that lupus goes up clinically. And so we know that, and that patients can go on for months with the activity, irrelevant of the clinical presentation, as we see in transplant patients that is with rejection. And this is why we have a very strong trend now, and maybe we can arrange for this one session, Yasser, that we can talk about biopsy in lupus nephritis, repeated biopsy in lupus nephritis. This would be a very interesting topic, and I will answer your questions. But in general, for any disease, not only lupus, if you are eventually going to biopsy, then why don't you biopsy and just manage your patient the way you want? But just take the biopsy first. Why do you make our life difficult? And why you give the patient treatment? And then you want an answer from me. Was this a tubular interstitial nephritis or is it an acute tubular injury? How would I know? You gave the patient already steroids. If the story started with tubular interstitial nephritis, the cells are gone. And what is left is the residual tubular injury. If he had tubular injury from the beginning, you should not have given him steroids. So this is what happens every time. Does she have lupus activity? This is a low score. Again, you've treated the patient, the biopsy is late. What I see is more chronicity rather than activity. You get a low score of activity. You're wondering, why did you give her cyclophosphamide? When actually all what you've done was that you modulated the histological picture. So treatment modulates histological picture, yes. If you want to get a proper diagnosis of the current condition of your patient, then biopsy, then do whatever you want. If you want to plasmapheresis, if you want to give her anything you want, just go ahead. But biopsy first to preserve. Biopsy, as I always say, is a snapshot at a time. So
Yeah.
if you want to record this time, you need to have it in this specific time. It's always helpful to have biopsies as early as possible. If you're taking a biopsy for follow-up or prognosis, then you are justified to start treatment first. And you can start treatment, you don't have to wait for the result of the biopsy.
I can remember, in a comment for this, I can remember one of from UK professors who came to our conference in Cairo University many years ago, and he was discussing cases of lupus, and he was trying to tell us how much it is it easy to treat patient with lupus without a biopsy, no need for a biopsy, and we can go with a biopsy. And I raised my hand and asked him a question that, please, I want to ask you a specific question. Did you make a biopsy for all of these patients at any point of their clinical course? He said, yes, at some time of the clinical course, I did a biopsy for all of these patients in spite of starting treatment empirically and trying to treat without a biopsy. But at some time, I need a biopsy to decide where I am standing and where how can I proceed further in treatment of this case. Thank you for illustrating this point.
Thank you very much. And this is what I'm saying. I'm not pushing for a biopsy. I just want you to remember, always remember that biopsy is an invasive procedure.
Yes.
So when you're having an invasive procedure, and it's a costly procedure, currently it became expensive. So if you're having an invasive, expensive procedure, then what you should have in mind is to maximize the information that you should get from this procedure.
Yes.
So this is always has to be the way you think in relation to a biopsy. How can you maximize the information you're going to get from this biopsy? You're already having an invasive procedure. The patient is going to pay that much for it. It's already expensive. Already the patient is going to have the risk of the biopsy. So you're having the side effects. So what you should push for is maximizing your benefit, maximizing the information of what you should get. You should plan the time well, know what you want to know from the biopsy, and then this will tell you when you should biopsy. And as I said, that you want to treat and that the patient is urgent and you want to have to start treating quickly. No, I'm sorry, this is not an excuse. Biopsy and start treating before you get the patients off the biopsy bed. So this is just what I'm saying, because it's really bad, and I feel bad and sad when you eventually have to biopsy the patient, and then all what you see is chronic changes, and we're not able to know what was the original diagnosis. And so this was a wasted effort. Okay. You subjected the patient to an invasive procedure, and we wasted time. Okay. And so I want you all to consider always this when you're thinking about biopsies.
هو المشكله برضه دكتور وسام ان هو sometimes الكيس followed خصوصا اللوبس followed by rheumatologist ورheumatologist الى حد ما بيبقوا more aggressive even في treatment فهم يعني ساعات we receive some referrals from rheumatology about a lupus patient already received 2 doses of cyclophosphamide for the past 2 months, and now patient is more deteriorating, not responding about kidney function and nephrotic syndrome, and they're asking about kidney biopsy. So for most of time, we are refusing to do a kidney biopsy. Already you started treatment. There's no.
No, you should. But you should always mention to the pathologist that the patient was on treatment. So if you meet and the patient is not responding, so there could always be the question that there is something else can happen. If Yasser would give us some time later in a couple of months or 3 months or maybe earlier than that, this is something which should be discussed. That
yes, of course.
Yeah,
I was about to discuss it with you.
Yes, biopsy in lupus is a very important issue.
I was preparing for this. And I was about to tell you about this to make a series of sessions about this topic, specific session.
Thanks.
I have a question.
Professor Dawlat, please.
If there is a lapse, an unavoidable time lapse between starting the treatment and getting the result of the biopsy, what is it that can be distracting in the pathology?
If it's unavoidable, it's unavoidable. But it's always good to know, because then I interpret.
Right, I understand.
I interpret the findings within this. What can happen is that you start chronicity. What clinicians are not aware of is that patients do get into end-stage renal disease within 2 weeks. Just
I
2
have a
weeks.
question I always wanted to ask. If you have successful treatment for a lupus case, does the pathology improve? Does it go back from stage, say, 4 to stage 3 to stage 2? Is this possible? Is this confusing?
لا مش فاهمة السؤال. I don't
Yeah.
understand the question.
If treating started in an unavoidable situation, he does
Okay.
not have a chance to have a biopsy, or the biopsy is going to take some time for shipping and coming back, and he
Okay.
starts. How is it going to change the pathology of the case? If it's stage 4, and he started cyclophosphamide and steroids, and got for say 2 cycles, what will happen to stage 4? Would it go back to
Because
stage 3?
it's not, they are not stages, they are classes. And could be wrongly misinterpreted. So what you're gonna see or what you're gonna get in a patient who's treated and which is class 4, first you're going to have, yes, you're going to have a scoring of a class 3 because then the activity is less, but then it's active. And then if I know that she's treated, then you'll probably have class 4.
Yes.
But you're going to have a lot of chronicity. So you wouldn't know.
Chronicity because
You
of the
needed to
progress
give,
of the disease, because of the time.
because of the progress
I mean, but
disease.
the
Yes.
treatment
So
is
you just did
it's
not
not
have.
going, is the treatment going to initiate chronicity? I don't
No,
think.
no, but the treatment modulates the picture. What I know, and correct me, is that also you need the scoring and you need to know the presence of crescents and fibrinoid necrosis to decide which management protocol you're going to give the patient, right?
Right.
You need to know which class you are in order to know how are you going to plan her maintenance immunosuppression. If this is going to be modified by the chronic element, then I cannot tell you which class exactly the patient started on, whether she was class 4 or 3. I cannot tell you whether she had crescents and justified, and was the cyclophosphamide justified or not. Oh, this is usually yes, this is what I'm saying. It depends what answers are you looking for. If these are the answers you're looking for from the biopsy, then delaying the biopsy or treating the patient first is not going to answer these questions.
No, I don't think it's intentionally delayed. It's because just
I understand. Yes, of course.
testable situations, which happens all the time.
Yeah,
I mean,
and when we know
in Aswan or somebody far away. And
by the time they come, yes, of course.
So he has to start treatment. This is the problem.
Yes, we're talking about the usual scenario, not about unavoidable situations, of course. And sometimes the patients have very low platelets, you cannot biopsy. Sometimes the patients are distressed. There are so many scenarios where you cannot have an immediate biopsy and you have to start treatment. Of course, this is accepted.
And sometimes they refuse the biopsy.
Exactly. Now, this is not this is not accepted. Yes.
Final question.
Clinicians should do more effort to make patients have biopsies because, as I say, it affects the overall prognosis of these patients.
Yeah.
A final question from Dr. Khaled Abu Zaid and command, please.
السلام عليكم دكتور ياسر. السلام عليكم دكتور وسام. دكتورة دولة، ازي حضرتك؟
ازيك دكتور خالد؟ ازيك حضرتك؟
اخبارك؟ انا بس I have to comment يا دكتورة وسام. الكومنت الاولاني انت بتقولي ناسيه انت خدت التريننج بتاعك امتى؟ اعتقد ده كان السنه اللي فاتت، يعني مش
هو يا دوب حلو، ما ينفعش يبقى عيب.
وانا شايف.
الحاجه الثانيه انا I think we are in need for nephrologist, professional nephrologist in every center have nephrology department. لان في الحقيقه we need for urgent revision for every biopsies with a nephrologist. انا معاك، انت بتزقينا دايما دو رينال بايوبسي مش انت اللي بتزقينا. احنا دلوقتي الخناقه بقت معانا احنا as a nephrologist why you did too much renal biopsies. في الحقيقه من other specialties maybe من المانجمنت sometimes maybe من الانشورنس كومبانيز. وعشان كده القصه بالنسبه لنا is not مش ماشيه في الساينتفك واي. انا بعمل الرينال بايوبسي وبعدين ابعتها لحد نون بروفيشنال يقوم يقراها لي في الهند في الصين في اي حته في المريخ نون نفروباثولوجيست، وبعدين يجي لي بداتا مالهاش علاقه خالص بكل الداتا اللي انا بعتها له كلينيكال. وبالتالي ده دايما اللي بيحصل، اللي بيبقى العيان فيه بيفقد فرصته في انه جيت هيز مانجمنت بروبر. وعشان كده في الاخر بعتمد بالرغم ان انا اخد رينال بايوبسي بعتمد في الاخر على ماي كلينيكال سنس ان انا ادري العيان البروبر مانجمنت بتاعه. وعشان كده هتلاقي الكونفيوجن دايما مننا از نفرولوجيست. احنا ابتدينا العلاج قبل ما ناخد البيوبسي، ابتدينا العلاج بعد ما ادينا البيوبسي. طب هيتغير؟ الباثولوجي هيتغير، ديفينيت هيتغير. لكن انا لو عندي نفروباثولوجيست بروفيشنال وافيلابل وكان ريفايز وذ هيم الكاتس افري داي، وايه اللي ممكن نعمله، هنزود ستيننج تانية ولا لا، هنعمل immunohistochemistry، هنحتاج الكترون ميكروسكوب ولا ما نحتاجش. كل الكلام ده I think we have to take a decision with a professional nephropathologist available in my center if I have a nephrology department settled. I
Thank you.
don't know يعني your comment as regard this opinion, but أنا أعتقد إن هي مش هتكمل غير بالصورة دي.
Thank you,
ما
sir.
طبعا
تبقاش إن
فعلا
أنا باخد بايوبسي وببعتها من far away
مش
واستنى
انت مش انت
وهو
بس
له
مش انت
وجهة
بس
نظر وشايف الباثولوجي بطريقة وأنا شايف العيان بشكل مختلف ومفيش أي كوميونيكيشن ما بيننا. إيفن حتى حضرتك بتشتكي من الريبورت اللي بيجي لك فيري ديفيشنت ريبورت، واقول لك يلا اقري الباثولوجي، اقري العينه، وقول لنا ايه اللي شايفه فيها ايه، كانك هتفتح المندل. معلش انا اسف
Very clear
باللفظ.
message. Thank you, دكتور خالد. شكرا.
Thank you very much يا خالد. very valid comment. طبعا ان السيناريوز اللي احنا بنتكلم فيها دلوقتي ده والديلي مش applicable على الاماكن relevant للايكونوميك situation. يعني في بلاد very rich and they do not have renal pathologists as well and have the same problem and have to start management with the patient. أو إن biopsies are sent very far away and it's going to take 10 to 12 days, sometimes up to 2 weeks till they have a response on their biopsy. They cannot wait. There is no direct communication with the pathologist. All of these are problems faced في دول كتير غنية وفقيرة. It's not related to economy as much as it's related to the lack of presence of experienced renal pathologists. طبعا this is valid محدش بيقدر يتكلم فيه. احنا بنتكلم بس على situation. هنا في مصر في renal pathologists والناس بتقدر توصل لهم وبيتكلموا معاهم وموجودين في كذا جامعة. فاحنا بنتكلم على السيناريو يعني اللوكال الحقيقة. we're talking about more or less our local scenario.
Thank you so much. Thank you. No more comments and no more questions, and I think we are to end this very fruitful session. Please, Professor Daulat, your comment.
Thank you very much, Wesam.
Thank you very much.
I congratulate you for the fourth case. And you had a very high suspicion index that you looked for kappa and lambda, which probably would we have passed this lady as end-stage diabetic nephropathy. Probably. Yani, I really congratulate you for this case. Thank you very much.
Thank you, Professor Daulat. Thank you, Sam. Professor Wesam, for this.
Thank you very much.
Very, very interesting session, very interesting cases. And you can see the responses are very encouraging, and we're very encouraging. And for all of the 4 cases, and I congratulate you for really for all of the 4 cases. Thank you for all professors who shared us, Professor Hisham Al-Sayed, Professor Saeed Khamis, and for all Dr. Khalid Abu Zaid, Dr. Muhammad Abdel Bari, and for all attendees for their share and for their response, for every question and for every case, and for enriching this session with their comments and answers and making it a very fruitful, interactive one. Thank you so much, and excuse me to close this session and announce about the coming one, which will be next Wednesday, 9 p.m. Please, 9 p.m. 9 p.m. even in our summer time. We are in usual time. Wednesday, 9 p.m. will be a clinical forum of the Azig University or Zagazig University, and coming Wednesday. Thank you so much, and excuse me to close. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام. شكرا.
شكرا. مع السلامة.
شكرا دكتور.